Hey, thank you everyone for joining this month's PFA Network monthly coffee chat. I'm Lindsay Galley. I'm the Vice President of Programs at PFCC Partners. Our organization facilitates the PFA Network, or the Patient Family Advisor Network. Typically, these meetings are led by Libby Hoy, who is founder and CEO of PFCC Partners, but she is flying back from it sounds like a very interesting conference in Alaska right now. So you are with me today, but we have an interesting topic for discussion today, and I'm really interested to hear some of your experiences around healthcare workforce safety and violence prevention. It's a rather large challenge that healthcare organizations are facing, and wanted to bring this topic to all of you, patients, family caregivers, patient family partners, patient family advisors, to hear some of your thoughts and experiences around healthcare workforce violence prevention, and your thoughts on how we in the positions that we're in can ensure that these instances of violence don't happen to our treasured healthcare workers. So we'll gear up for that discussion shortly. Here are some Zoom features. I know we're all quite accustomed to Zoom over the past few years. There are a few things that I need to do. I'm going to go ahead and turn on closed captions for anyone that needs them. You can find those by clicking CC on your Zoom toolbar. We have a smaller group today, so I'm not too worried about folks speaking over each other. But once we get to our discussion portion, if you would like to use the raise hand button, that will just let me know you'd like to come off mute and share. And then, of course, please use the chat to chat in your thoughts and ideas, anything you would like to share there as well. So before we get to some introductions, wanted to go over our agreements for our meeting today. We like to use these just to make sure we're all in a safe place to learn and share together. So you can take a moment to quickly read over these. I think the one that I like the most is stories stay and lessons leave. So any stories that you'll be sharing in today's session will stay here, but the lessons within them will come with us. And actually, on that note, we have been testing the use of AI note taking in Zoom. So I am going to turn that on right now. This simply just captures conversations and action items and things that we need to go back and recheck. But anything that you do share, we won't place any attribution to you unless you ask us to share more broadly. So I've just turned that on as well. All right, let's do some quick introductions. Um, I think we have a small enough group that we can just kind of go around the horn and share. Would love to just hear your name, your location, and if you have ever witnessed healthcare staff being mistreated by patients or their family caregivers. I know it's a rather big question, but just curious if you have witnessed that in your own, personal experiences. I'll start. I'm Lindsay Galley. I am located in Sacramento, California, where we're finally gearing up to spring-like weather, which I'm excited about. It's been too rainy up here. I personally have never witnessed healthcare staff being mistreated by patients or their family caregivers, but I have heard many stories, some quite horrific, of the healthcare workforce having rather difficult experiences with patients and family caregivers. So I know that there's a lot of stories out there, but I myself have not experienced that. personally. All right, I'm going to pass it off to Sal. You're the first one on my list.
Probably the last one to show up, but anyway, I'm
Oh, that's
here.
okay.
Yeah, I live in South Lake Tahoe, so I'm just down the road from you,
Yeah.
a couple of hours. And let me see. I don't have any personal experience with this thing but what's interesting, I know of well, actually, it was my therapist who had to do a report of one of her clients was being mistreated by caregivers, family caregivers.
Mm-hmm.
And so she said that, and the therapist was obligated to report it because
Oh,
you're
yeah,
obligated to, yeah, elder abuse.
right.
And so she was obligated to report it. That's the only experience I know of anything.
Okay. Well, thank you for sharing, and maybe some more of that will come up during our conversation. All right, thanks, Sal. Let's go to Karen.
Hi, I'm Karen Anthony. I'm in Silver Spring, Maryland, outside DC.
Oh, Silver Spring. Yay.
Are you Silver Spring, Sal? That's nice.
I lived in Wheaton.
Oh, right up the road. Right, I count that part of my neighborhood too.
Mhm.
Um, the Have I witnessed healthcare staff being mistreated? What I would count with that is the kind of verbal abuse that I've seen a lot of, not physical abuse. And that's such a tricky one that I'm interested to hear the nuance of that, because people are not at their best under such
Right,
incredibly stressful circumstances. And what one person says is fine, and I can just sort of let slide, is not fine for everybody, and can sometimes have an overreaction and get yourself into a very messy situation. So how you work through de-escalation of that kind of situation, I'm interested in
right.
hearing about. Not the physical violence. I've heard all the stories of that
Yeah.
are terrible, but I think what you see a lot of is the verbal abuse and
Mhm.
that part of it.
Yeah, yeah. Thank you for sharing, Karen. Let's go to Chris.
Hi, everybody. I'm Chris Severson. I'm located in Reno, Nevada, just down from Sal. We
Mhm.
also are experiencing some spring, yay. Um, I unfortunately have seen so much of this. The first 10 years of my career, I worked at a hospital and in the employee benefits and employee relations department. And we would have workers' comp claims filed all the time. And probably the one that I will never forget, I know that there's a lot, but a nurse was leaning over a patient and the patient bit her right
Oh,
in the, you know,
not
in
a
the
good
sore.
spot.
Yeah. And I thought that has got to be the weirdest workers' comp claim I've ever seen. It wasn't, but it happens all the time. Most recently, I had surgery about a year ago and I was in the like pre-surgery area. And there was a patient that was just horrific to the healthcare staff. I mean, just um, the things that he was saying to them were things that I would never want repeated to anybody. And he was calling them racist, and he was calling them, all kinds of names, and I'm going to come after your family. And I mean, it was
Oh my
just
gosh.
really, and I was like, I just wouldn't put up with that. You know what I mean? But healthcare workers, oh my gosh, the things, like I said, the things they have to put up with are
Right.
just horrible.
Yeah.
I,
Yeah.
I, so yes, I've seen it a lot, both personally and professionally.
Wow. Yeah. Thank you for sharing. And it kind of goes to Karen's point about some of that more verbal abuse too,
Yeah.
that can take place. Thank you.
Mhm.
Let's go to Erin.
Hi, my name is Erin, and I work at Brigham and Women's Hospital in Boston. I'm the program manager for our patient family advisory councils. Um, Unfortunately, we've seen the department I work in is the Center for Patients and Families. We take any complaints and grievances for the hospital. So unfortunately, we see a lot of this. But
Mm,
we have our hospital has kind of established a code of conduct that staff and patients and families are all expected to adhere to. Encouraged to call out in a respectful way when we think that there's mistreatment, and hopefully be able to resolve it in the moment. So yeah, there's a lot of examples.
Oh yeah, yeah, lots, but that's exciting to know, you have some structure in place to address things like that. I've heard of hospitals using code of conduct before also, so that'll be really interesting to hear more about as we get into our discussion.
If I could just make one comment, I was at the doctor's office on Monday and they had like this huge banner that talked about about treating everybody and treating their staff, and that they have zero tolerance for verbal or physical or anything. So it's the first time I've seen it in a doctor's office, and it was huge. It was like this really big banner. So obviously they've experienced it and just
Yeah.
wanted to let people know that it would not be tolerated. Sorry to interject.
No, but that's really interesting that you brought that up, Chris, because that's one of the reasons that sparked this conversation and us bringing it to the network is seeing the messages that are put out to patients about, workforce violence and those sort of messages, and how certain hospitals or healthcare organizations approach those messages. Some are a little bit more aggressive, I guess I could say, and some are more like this is a healing space. Yeah. So let's talk more about that once we get to that discussion point. But yeah, interesting you brought that up. I see, Molly, I see your chat. Molly is a family advisor from Children's Nebraska, is a little in and out right now. So jump in when you can, Molly, but thanks for joining. All right, let's go to Laura.
Hi, I'm Laura Winterstein. I work at Health Fairview in Minneapolis, Minnesota, and I work in volunteer services, but also with engaging patient family advisors and 10 acute hospital sites. I have not been witness to healthcare staff being mistreated, but I know that at some of our emergency departments, we've been taking steps to reduce physical violence. But I'm very interested in hearing more about how we can reduce some of that verbal violence. I know we are aware of it in our annual required learning. We do have slides on workplace violence, and it's very clear that we should never accept it as part of the job. So
Right.
I think sometimes people can get into that mindset that it's just part of what you have to do within your day, and no one should ever have to do that.
Right. No, that's a really good point, because you don't go to any other job where things like that can happen. Like I wouldn't expect that to happen here in what I do, and I'm sure for others as well. Thank you, Laura. Let's go to Mary.
Good afternoon, everybody, or good morning, depending on your time zone. My name is Mary Buddy. I'm from southeastern Wisconsin. I've actually witnessed violence twice. One was verbal, one was physical. Many years ago, I worked in the lab at a hospital, and there was a phlebotomist who was actually a college student doing her last internship of medical technology. And a patient hit her just about before she put the needle in his arm to draw blood. And she didn't want to report it because she was worried she had done something to not de-escalate it. I mean, this was a 21-year-old who was more concerned about that. And that was kind of a wake-up call for me. And the other time I've seen is my mother was in a long-term care facility, and there was a resident there who was pretty verbally abusive to a number of the CNA there. And I think they also kind of struggled with what's too far.
Right.
Especially among patients who maybe have some dementia. But I think they struggled with that. And so I think this de-escalation discussion is really important, because I think it's difficult for care providers to find that line that says, that's enough. And now I need to react.
Yeah. Thank you for sharing that, Mary. Yeah, I think we'll get more into that discussion. I do want to say, we don't have all the answers here. Hoping this collective group of really smart, experienced people and patients and family caregivers have some new ideas on approaching a very serious problem in the healthcare workforce. So thank you. All right, Cheryl.
Hi, I'm Cheryl Chadwick from Children's Mercy Kansas City. We are a freestanding pediatric hospital. I am a parent on staff, first coming there as a parent and now hired and work with our 22 patient family advisory councils. I have not personally seen it, but I have heard many, many stories. And on our website, under our, like if you look up our patients' rights, we have patients' rights, responsibilities, and rules. And at the top, it says these rules are for everyone, including staff, patients, families, and visitors. And so it specifically calls out what to do and then what to do not.
Nice. Nice. Well, I'd love to get some of these examples too. If you have links that you'd like to drop in the chat, or documents that are worth sharing around this, like patient code of conduct or rights, we would love to see those. But I appreciate you sharing that, Cheryl. All right. And last but not least, Terry. Thank you for sharing that.
Hi, I'm Terry Savino. I'm the Director of Service Excellence and Patient Experience at Middlesex Health, and I do facilitate our Patient and Family Advisory Council. I am a critical care nurse by background, so I have seen some of the patient violence, and most of what I've seen in my role in patient experience is verbal abuse, because often I may get called to go up and help staff, and I really encourage them that they need to be respected in their role. And when the visitor or patient can speak to them respectfully, then we'll talk about it. But I certainly support them to step away if they feel that environment is unsafe for them. And we in the state of Connecticut actually have a code of conduct that was facilitated through the Connecticut Hospital Association. We actually had ours before the state rolled theirs out, and we do have pretty big posters on every single unit and in the ED that talk about the expectations of staff and patients and visitors, and we have a zero tolerance for any violence.
Thank you for sharing that, Terry. And I like what you said about respect there. I think respect and trust come into that caregiving relationship a lot. So yeah, I would be interested to hear more about, yeah, what we can do to help patients, because you have to really quickly build that trust and relationship. So challenging positions for sure. All right. Well, so just to keep level setting our discussion, had some quotes that I wanted to share here. Obviously, it sounds like everyone is well familiar with this challenge in the healthcare workforce. So we have this from the American Hospital Association that overall healthcare professionals are 5 times more likely to experience workplace violence than workers in other fields, just exactly what we were talking about. So that's from the American Hospital Association. And then this from the CDC starts to add some kind of attribution to the reasons why workplace violence is increasing. So it says staff shortages, increased patient morbidities, exposure to violent individuals, and the absence of strong workplace violence prevention programs. And protective regulations are all barriers to eliminating violence against healthcare workers. So there are a lot of barriers in place to help prevent violence within the workplace. But I still think that there's plenty that can be done. And so would just like to start the discussion here. And so my first question is, were you aware that this was such a big issue? And I think part of the reason why a lot of you are here is because you are aware of that and would like to, continue brainstorming thoughts and ideas around prevention of workplace violence. But just wanted to see if there was any other reflections or thought around, how big of an issue that this really is.
Can I jump in
Go
real
ahead,
quick?
Sal. Yeah.
I've been watching this series on Netflix called The Resident.
Mm-hmm.
And I'm assuming that they are portraying stuff that really happens in hospitals.
Mm.
And they portray as people being bitten, healthcare workers being bitten, kicked. They try to restrain them long enough to, kind of calm them down, and they hit them or kick them as they're trying to do their jobs. I'm thinking, well, I guess this is a big issue if they're portraying it here on this series
Yeah.
that it happens,
Mm-hmm.
in people who they come in, they're kind of indigent, or they're loaded on drugs or that kind of thing.
Right.
So
Yeah.
I don't know.
Yeah.
We have
No.
we have a small hospital here in Tahoe. I forgot to say I belong to the advisory council for that hospital. So we have a small hospital, so we don't see the incident. I can just imagine what Sacramento, San Jose, LA,
Yeah.
places like
Bigger places. Yeah. Where unfortunately, there are lots of substance abuse issues too that come up and come into play when it comes to workforce violence as well. But yeah, I think, shows like that, documentaries and things really start to raise awareness around how big of an issue that this really is. But thanks for sharing. Yeah, Karen?
So I'm on the PFAC at Children's National in DC, and we've had staff come to us in various places to talk about security or to talk about signage that talks about the policy from both a calming or a healing place perspective, as well as here's the things that are not allowed for you to bring into the hospital, like weapons and drugs and alcohol and that sort of thing. And the place that I don't want to speak for everybody, that I often struggle with that sort of, with the signage and the messaging that goes out, is that, first of all, I don't think a sign is going to prevent someone from making a choice to be violent. I think
Right.
that's fine to say what it is, because then it puts a line in the sand. But if someone is going to make that is going to act that way, that the sign's not going to slow them down.
Mhm.
And I worry that it creates an environment where it looks adversarial to people that are coming in the door, where it's saying, don't act like this, don't do that, we suspect you of doing the wrong thing. And I struggle with that when you have a place where people are coming in the worst moments of their lives, where people are struggling with mental health issues, or whatever it is that's making it harder for them to manage, and they're very dysregulated. You don't want them to come in and then have to feel that they're going to be in danger. It's not that I want at
Right.
all the healthcare professionals, I want them to be safe, but we also want people to feel like even when they're in a terrible place and they're scared and they're upset,
Yeah.
that they're safe here and they're not going to be judged
Right.
for a loud voice. Or, I can remember a time when my son was upset in a room after getting bad news, and he's throwing things around his patient room. There needs to, figuring out how you balance the kindness that you want to show to people, but the safety of the healthcare folks
Yeah.
is really important. And I worry about how we create that environment with the messaging.
Yeah. No, that's a really great point, Karen. And we've heard the same similar things, that it does create a line in the sand. It actually sometimes make patients not feel safe. Like, why do they have these signs up? Like, should I feel endangered? So I think that's really interesting that you brought that up. And I see, whose message is that? Oh, Aaron's. That when they started the code of conduct, also some parents were offended, saying this is how you should act when you're in our hospital. That's a hard thing to hear as well. I'm curious thoughts. So I have some more questions here, and one of them gets to that signage piece as well. But because I know we have some health system partners on, or hospital partners on, but even our patient family advisors on, have you seen health systems start effective prevention programs that go beyond signage or a code of conduct or a policy, something that's been really impactful?
I know that when they did some safety work at Children's, there was also an effort for training staff around de-escalation techniques.
Right.
And not just saying we're going to call security, but that what they were doing was calling a wider team, much like you would in a critical response for if it was a medical event. So you would bring a social worker to the space where there's an argument happening and you want to de-escalate, and teaching folks how to manage it before it gets to that point. And I thought that was a really nice holistic perspective to bring, rather than just an authoritative, punitive sort of response.
Yeah, because someone might not need security to be coming to their room, but they might need somebody, a third party to talk to, dig a little deeper.
So I kind of have a, I don't know, no tolerance perspective, and maybe it's because I was in human resources most of my life, but I'm convinced that I will see a very I don't know, I will see a large scale or impactful workplace violence situation sometime in my career. It wasn't, for me, it became not a matter of if but when, because they're so random, right? They're so random. You never know where you're going to be. You can be at the grocery store or driving your car or whatever. So I applaud any steps that organizations take to have a zero tolerance policy, whether it's, armed guards, or whether it's, restricted access points for family, or I just, early on in my career, I just said, you know what, I don't have to put up with this crap, excuse me, but or neither do my employees, that if they're being treated badly, or if there's, and if there was ever a hint, even a hint that something could go sideways, we shut it down. When we said that we take all threats as real, whether they're just or not. And people didn't like me much for that, but I mean, I don't really have a lot of, I don't know, maybe it sounds uncaring, but I'm okay if it bothers people. That those statements are there. I think that if it
keeps everyone safe.
Yeah.
Right. Yeah. Can definitely appreciate that. I had a thought and it just left me, but we can come back to that. Any other thoughts on prevention programs? I remember what I was going to say. So we work a lot in Los Angeles County, and I don't know if it's all of their health centers or if it was, I think it was just one hospital or a rehabilitation center in particular, where they were adding metal detectors to their entrances. I think a lot of other hospitals maybe do that as well. Karen, I see your head nodding too. And they came to the advisory council there to kind of talk through, how can we describe the purpose of, why we have these metal detectors, to make sure that people are coming to a safe place and feel like they are safe. So I, just wanted to add that as far as, prevention programs, but it is kind of off-putting because you're like, I'm going to the hospital. I should feel safe here. Why do we have metal detectors?
I also saw, I'm sorry, go ahead.
Oh, no, go ahead. Go ahead.
I didn't put my hand up.
Okay.
We do have a hospital here locally that you have to get a badge. I saw the question in chat. You have to sign in, you have to get a badge, all visitors, so they know who's in the building.
Yeah, I think that's true, at least for most hospitals I've visited and the ones we work really closely with in LA County. Yeah, you have to get a badge. Oh, I didn't see your chat in there, Mary, and I see your hand up, so go ahead.
So I live in an urban area, and almost all the hospitals here have had metal detectors for quite some time, at least at the emergency room. So that makes it a little bit easier for somebody who wants to add them. I'm curious about the badging system that includes like a scan of an ID. Like I get like the paper ones, but I mean like there's one hospital here that has a badging system where you scan your ID, it checks against a list that the security department keeps at the hospital of visitors who have in the past been violent. And then security addresses that. It apparently also has the ability, which they don't use, to check against like outstanding warrant registries and that kinds of things. And I think a lot of people around here talk about how off-putting that is. But again, especially like the Children's Hospital here, I am hard pressed to see a valid reason to not be happy with that if you're a patient or a patient family who's not going to hit any of those registries.
Mm-hmm.
So I'm curious if anybody has like that depth of a visitor badging system and if it's helped.
That's and more intensive than what I've heard before. But yeah, I would love to hear from others. I see Cheryl and then Karen.
So at Children's Mercy Kansas City, we do have all visitors into the hospital have to go through the system where they have to give an ID and then they get a badge. It is only checking for like sexual predators and things like that. It does not connect to like the patient's charter. We do not have a visitation database that shows troublesome visitors. We do have a process in place where like security and the team gets involved if there is a visitor that has been disruptive, that they have to like sign an agreement before they can come back. And sometimes they have to be accompanied by security. So we do have that in place. We also recently went from metal detectors to weapons detectors. And the difference is that it checks for like, I'm not going to use the words right, but like the mass that someone has, as opposed to it supposedly gets more. It does set things off, like some of the strollers, like it sets off so then security, they can see like where the alarm is alarming and they can tell, oh, that's just the mechanism of the stroller that's setting that off. Or if it's like in a backpack, then they actually physically check the backpacks.
Mm-hmm. Interesting. I hadn't heard of that. Thank you, Cheryl. Yeah, Karen?
Yeah, we also in Children's National have the check-in with the badges and photographs on your badge. We don't have the depth that Mary was talking about. We do have that same sort of screening like Cheryl was discussing. And when they started using it, the head of security came to PFAC to talk about, we're going to run this for a couple of weeks for a while because it's AI generated actually. And it's going to learn, and people who come here are going to learn, oh, look, umbrellas go off all the time, or strollers go off all the time, or people, wheelchairs or other medical equipment can set it off. And it would start to learn what things are commonly coming through, and you'd have more folks doing it. I thought that was a nice way to do that. What I would worry about in the system where we're looking at outside the sexual predator thing, for sure, you want to be safe in a children's hospital, but there's so many times where people have outstanding somethings that involve the judicial system or law enforcement that may or may not be a danger to anybody. Maybe a misunderstanding, maybe they didn't pay bail, maybe there's a divorce decree that's not, like, there could be so many problems with that I worry about trusting any flags that come out of that system and automatically saying, well, you can't come in here because whatever, who knows what that answer could be. You have too many parking tickets or something. And there's not a system to adjudicate something like that on the spot for family members who are just trying to come in and take care of their child when they're going through something difficult. So you want to be safe for sure, but you also want to make sure that there's equity in the way that's being applied, because that is the part that is, there's judgment calls in that is not about who's running security.
Yeah. I appreciate how you stated that, Karen, because I could really see, both sides, how you would want something like that in place. But yeah, what if it is something small that limits a family member's being able to take care of their families? And then I also think Because again, in LA County where we work, there are a lot of immigrants who are undocumented. So when it comes to that, how does that get addressed, or how does that affect, who they can or where they can and can't go? And with our work with LA County, they had originally had a very lengthy process in place for volunteers and contractors to become patient family advisors. There were background checks, there were scans, there's everything. But we were able to put a new process in place that is just, this is kind of outside of our topic right now, but thought it might be interesting. We use a memorandum of understanding where the organization and the new patient family advisor, they sign that, just kind of solidifying the relationship in a formal way that gets documented, where they don't have to go through all of these processes that would limit their participation. So that's just an aside. But Sal, I see your hand.
Yeah, I wanted to say that we're a small hospital here, and it's a community hospital. And I've gone there a few times. You don't have to have like a desk for checking in or wait.
Right.
Sometimes there's nobody sitting there. I'm thinking, how many times has this happened in smaller areas? We're a rural area.
Right.
So a rural community hospitals, how often does that happen, that they step away from the desk and just anybody could just walk in and just keep walking in?
Yeah.
I appreciate what you said about large hospitals and the number of undocumented immigrants. Having to try to ID people like that, they're scared anyway.
Exactly. Yeah.
They want to be under the radar. How do you do that?
Yeah.
Anyway, that's what I got.
No, I appreciate you sharing that. I think it's really, it just shows the difference between what these sort of processes look like in a more rural community than an urban. And I feel like, preventing workforce violence is not a one size fits all. I think it really depends on your community, the resources you have, and how that gets addressed too. But yeah, it's really interesting. Yeah, Laura?
I wanted to speak to kind of the sort of disconnect, I think, sometimes where we want to have a caring environment, but then at the same time, worried about workplace violence. In our 3 urban EDs, we have those weapon screeners. So it's not a metal detector, but a weapon screener, like mentioned before. And the VP, the site VP, it's all one hospital, but we have 3 EDs. Has really been pushing for canine units to be patrolling the EDs. And our organization has flagged that as not a good idea because we have a large Muslim population that lives in that area that would be uncomfortable having dogs in their care environment. And so there's a real conflict, and they're at an impasse with the VP saying we need this additional protection to keep our staff safe, and the organization saying, but that makes it uncomfortable for people of a specific religion who won't want to seek help. So just kind of like teasing those apart.
Yeah, that's really challenging. And I see Karen's question. What would the extra value of the canines be?
I don't know if they would be like searching for drugs or if it would just be a show of force. But I don't think like having police or security patrolling is conducive to a healing environment. So I'm opposed to the idea because I just think it gets to what people have been saying, like people are very vulnerable when they come in and we want to care for them. And so kind of that balance of like, how do you care for them while keeping people safe and like not going to the extremes?
Right. And not putting people in a position where they're frightened or don't feel comfortable when they should feel safe and comfortable at the place that they're receiving care. Yeah. And it sounds like you're listening to the patients and the families and the community about the things that they would like to see and that want to see. And so some of it sounds like, there's having a patient family advisory council, and then there's really listening and putting into practice the things that are being shared by the advisory council. And I think those are two different things. So I'm sorry that you're challenged with that. But keep fighting the good fight. I know that's not a solution, but so all of this is kind of getting to my next question about like the messaging. And it sounds like it goes beyond messaging as to, what people are seeing when they come into the hospital, whether it's the weapons detectors, metal detectors, or canines, which I've never even heard as an option before, or seen that in a hospital or ER, which is interesting. But and I know, Karen, you had mentioned the signage, policies. They may not prevent someone who is already in that space to do what they're going to do. But I'm just curious from the group, what are some messages that may resonate with you or others versus messages that are more off-putting and scary or aggressive? I think what we have seen is the two different lanes of messaging, the super aggressive and the others that are more describing a commitment to creating that healing environment. But I'm curious if there are other messages that stand out, that you're like, oh, I didn't like that, or even other ideas about, how to message the importance of this to the patient and family caregiver population. And then we'll talk about going beyond messages, what we can do.
I don't have I wish I had a picture of the sign that we have at Children's Mercy. It's only in our pediatric intensive care unit. I'm so sorry, dogs. So sorry.
Right on time.
Yeah, I have a canine unit right here in my own home, and that neck's just pulled up, so he's not.
Oh yeah.
So the pediatric intensive care unit had some experiences where there was some instances. It was really between families. It wasn't between staff and families, but it was between families in the waiting room, obviously in very stressful situations. Their kids were in the ICU. So they came to our department, which is made up of parents on staff, and ran a sign by us. We did not care for it, but they went ahead and they hung it up anyway. Basically saying that violence of any kind is not acceptable, and that you will be escorted. You will be escorted out if you don't act nicely. I wish I had the exact words, but
yeah,
I have a picture. I can't find a picture of it really quick.
so that's the more aggressive approach.
Yes, it was,
to
and that's what we felt. It was a little too aggressive, but because they'd had so many instances, those that worked in that area felt that it was necessary. But it's just in the ICU waiting room, and it's not back into the patient rooms or anything. It's just in the waiting room.
Right. Interesting. Yeah, we were trying to gather pictures too, but couldn't couldn't grab some accurate ones. Thank you for sharing that. So yeah, definitely the more aggressive approach doesn't sit too well. Have any others seen messaging? I know, Chris, you had mentioned in the beginning some of that, but yeah, anything else to add on to that, or any others who have seen messages where you're like, yeah, I like that.
I just would be super curious about if people could document change because of this, because the idea that you feel better that the sign says, don't bring a gun into the hospital, which is one of the signs that I've seen. I understand why it might make you feel secure, because who wants to think that that's a possibility? Or that you say we have a zero tolerance policy. It might make you feel like, see, we told people. But I
Mhm.
want to know whether, did it actually reduce it? Because it feels like such a potentially superficial response
Mhm.
that is the easy one, and the hard one is what I would really like to see an institution going after, of what are we doing to help create an environment where people can feel safe and act safe in that
Right.
space, because you're getting all kinds of people under all kinds of circumstances. And if we said, oh, good, we're going to put up a sign, you also could say that's the end of our, we tried, we put up a sign.
Right.
And I would like to know what else.
Box.
Right, we
Yeah.
checked the box. We didn't know. That's like saying, well, we took your temperature, but we didn't really check to see whether anything was going to change in your body. We want to see whether something changed in the behavior.
Mhm.
I don't know, Lindsay, have you or anybody else know of any data about that sort of thing?
Not around signage, unfortunately. I might ask Cheryl if you know, has the ICU experience less instances of
You know,
violence?
I don't know. I could find out because I could go back, because we do file incident. We do encourage employees to submit incident reports to track those all. I don't have access to those. I don't get those directly, but I certainly could find out. But I agree, because that's what we said. You know, that sign actually may elevate my
Right.
anger. You know,
Yeah.
you can't tell me what to do or get in between me and my ex, spouse, or I think it could be antagonistic
Mhm.
for some. That's a really good question.
Yeah, or even put people in a more anxious state where they're more likely to lash out or
Well,
um
and for some of those difficult families, who are labeled difficult families, our team always asks the question, were they difficult before they came into the hospital, or was it something in our hospital processes that
right.
made that family difficult? Because I think at all times, I will include myself, there were times when I was a difficult parent because of what was going on, with my child in the hospital. So I think
Yeah.
sometimes we cause families to become difficult. And then there's just other people that are difficult on the outside world, right?
Right. Right.
And that's just who they are.
Yeah.
There's also an awful lot of data out there that how people are perceived as compliant or difficult
Mhm.
changes based on who's making that judgment and what perceptions they have about that individual person. People like that. That's somebody who's not speaking English, so I'm quicker to, they don't understand me, so I'm going to get louder and more. I mean, there's all kinds of, there is plenty of data that says that the perception of who's difficult is
Mm.
changes from person to person. And that's part of what the deeper work is that has to happen, right? Is so that people are good, the people that work there, not that you want people to be safe. I don't want anybody, any healthcare provider, to not be safe walking to their car. And that is, it's happened that people have been accosted, but you want them to be also not look at someone as a threat, to see someone as a threat just because they're using an angry tone of voice
Right.
and it's a big strapping guy that maybe you don't need protection from them, but you feel scared because that's what you're seeing.
Yeah. This all reminds me of an experience that my dad had shared with me. So I grew up with a sister who had cerebral palsy. She passed away about 20 or so years ago, but my dad, he described an experience where my sister was on a variety of medications for her seizures and other things. And my dad was very knowledgeable. My parents were basically nurses themselves. They learned everything that they could. And he saw a nurse coming in with a medication that he knew that if that was given to Emily, that it would not have been a good situation for her. So he physically had to stand between the nurse and Emily and say, no, you cannot give this to her. I'll have to go back and ask him like what resulted from that, but you're right. It's the systems that are in place. It's the implicit biases that people have that can impact how people react as well. So I just really appreciate that discussion. And it brought us to our last question here. And I know we only have a few minutes left and I have a few other items to go through, but, you know, beyond reviewing the messaging and the signage and the policies and the code of conducts, you know, what are other ways that patient family partners, patient family advisors can continue to support these prevention efforts? And I think some of it is raising stories like this and thinking deeper about, you know, how we're putting patients and family caregivers in positions, or, you know, how are we defining who's the difficult family member or patient, looking into those implicit biases and doing some self-reflection work. So I think there's a lot deeper, deeper prevention type processes or improvements that I think patient family partners can potentially raise as, you know, bigger priorities to address violence prevention. But just wanted to see if there were any other thoughts around supporting these efforts from the patient and family caregiver perspective. Yeah, Chris.
The only thing I could think of, I'm gonna lower my hand, is you know, to give physicians or hospitals the language or the verbiage or examples of what other people are doing. Like I said, at the doctor's office that I was at, you know, I'm sorry I didn't take a picture of it because it would have been so perfect.
We would have had so many pictures, I know.
But you know, maybe they need to put those in all doctors' offices, and doctors' offices either haven't thought about it or don't know what to say, you know, legal ramifications or whatever. But
right.
I would be supportive of helping the medical community to put more of those in place.
Yeah, and I think you mentioned like scripting and what to say around that, and I see Cheryl's comment that patient family partners can help with scripting for staff to explain the why behind some of these things. So
yep, and I know most of the employers that I work with, they want to push the easy button. So if I can give them something already done, they're much happier.
Yeah.
than if they've got to figure it out themselves. And I'm sure doctors are the same way.
Right. Yeah. And so I guess I didn't mention, you know, we're having this conversation here, but we're working closely with Convergence HQuick, Hospital Quality Improvement Contractors. This is something that they're really focused on with their hospitals. So there may potentially be more activities that come out of this conversation and our work with them, where we can potentially co-design, you know, processes, scripting, things like that, that can help others. So more to come. But go ahead, Karen.
I think also that patient and family partners are good at saying, what are the issues besides putting up a sign or putting the weapons detector? Because sometimes it's as simple as our hospital is so over the census is so high that and there's such an uptick in mental health crises patients walking in the door that safety is an issue, not because of what the hospital is doing, not because of what the staff is doing, not because of what the patients are doing, but because we're overcrowded, and that's leading to a dangerous circumstance.
Right.
And that's what we have to, that's the problem. We can't put a person who's having a mental health crisis in a curtained room where they're not carefully screened and monitored. Not that that's a thing I've seen, but the resources themselves of the environment is sometimes the issue, or the policy of when that is maybe not within your choosing of when you call the police, or those kinds of things. There's larger implications that I think it would be great to see patient and family partners really speaking about, and not, yes, I'm happy to read your sign, but what I'd also like you to do is tell me what else you're doing besides this that is going to really change what our environment is like.
Yeah, I really like that. It's a yes and so really raising patient family partners as leaders to be comfortable and speaking up and, you know, asking those questions. What more are you doing? I think that's a great idea. Laura.
I just wanted to follow up with that two of our hospitals, one in Minneapolis and one in a suburb, both have specific mental health emergency departments so that people can be diverted right into those if they show up at the emergency department with a mental health crisis. And it's helped decrease violence, but also for the patient, they don't necessarily need to be hospitalized. They just need to be stabilized and connected with
Right.
resources. And so it's been really helpful for patients themselves if they can have a calming place with recliners and, you know, fish tanks and activities and things like that, where it's low lights, really nice. And then maybe they stay for the weekend or 2 or 3 days, and then they can be discharged home without having to wait in an overcrowded emergency department or get admitted when they don't necessarily need inpatient care. They just
Right.
need some time and some help.
Yeah.
So
Wow.
it's been very successful for us.
It sounds like it. That sounds like an incredible resource. It's you just made me relaxed describing it. So there's some good stuff going on there, and you're able to see improvements too. So thank you for sharing that, Laura, and thank you everyone for this conversation. I think we've got some good ideas, good discussion, good lessons learned from all of you. And again, this conversation will continue with our work with Convergence. So if you see engagement opportunities come out around this topic, please feel free to jump in because I can really see the passion from all of you for this. So I appreciate it. And then I saw there was one resource shared in the chat. We can share that out after too, but if you have others that you would like to share, you can send them my way. I can put my email in the chat and we can share those more broadly as well. As we wrap up, just a few upcoming programs. I thought we were going to be joined by Karen Fernandez, but I don't see her on right now. But she has some great information promoting DES awareness that is located on the PFAnetwork website on the forum, so we can share that in follow up. You will be seeing, oh, there's Karen, right? You will be seeing soon some information about an Inspire Peer Connection Summit. This is open to all people with lived experiences, and this summit is really just a chance for people to come together and learn from one another with, you know, no specific end in mind, just to create connection amongst this community through our work on the Inspire project, which you can find more information on the PFCC Partners website. And then finally, coming this June, we're really excited to start a 3-part Writers Club with PFAnetwork member Barbara Kibowitz and our PFE specialist, Naomi Williams. They'll be going through 3 parts, guiding people on how to craft their patient or family caregiver experience into a story and how to share them. Lots of really great pieces there. So more information coming on that soon. And then before I pass it to Karen, I'll just wrap up with this engagement opportunity. This is an interview and focus group engagement opportunity for the Stanford Medicine Chemo-Induced Neuropathy focus group. So if you have experience with chemo-induced neuropathy, you can let us know, send me an email, and we can help you get connected. And Karen, I see you are on. Did you want to talk quickly about DES awareness?
Yes, thank you very much. I just came off of another Zoom call with AARP for nursing engagement. But thank you for letting me have a couple moments. This is a very important month for those exposed to the drug diethylstilbestrol in utero. Either you're exposed in utero or you're a DES grandchild. We are hosting the annual DES Awareness Week, the April 21st to the 27th. And we are publicizing our new pamphlet that's available to those that are exposed to the drug, and it's a good tool to give to your physicians. And I just heard this week, we have one member that's very, very active. And on April 27th, in honor of DES Awareness Week, Niagara Falls is going to turn to our colors. So it's something that you can watch live, which is really good. We've been very busy promoting DES Awareness Week to the media and anyone who would listen. So hopefully we'll get some action there. And I was able just to speak to the National Academies of Science Office of Women's Health on DES and what they need to be looking for. So Lindsay, I can share or put it onto our forum, our DES Awareness Week, and then our pamphlet. You know, it's all available. How would you like me to do that?
I just found your post in the PFA Network forum, so I will put that in the chat for folks, and then
Okay.
we will follow up with it as well.
Okay, perfect. Thank you. And you know, it's coming up, and we're just so excited to get the word out. So thank you again.
Yeah, thank you so much for joining, Karen, and sharing. We really appreciate it. So we have lots to follow up with, the engagement opportunities, a recap of the discussion, and then some of these upcoming programs and events. A lot of this information is on the PFA Network forum website. The link to it is in the chat. You can find it by going through Karen's post in there too. And then if there are any other topics that you are interested and excited about and would like to bring that to a future PFA Network coffee chat, you can complete this form and we can get you connected to the PFA Network for a future discussion. All right. I am going to wrap up there. I really appreciate everyone joining for this discussion. I know we went a few minutes over, but lots of great stuff going on, and yeah, looking forward to continuing discussions with all of you. I know most everybody dropped off, so all good.
Okay.
Thanks, Lauren, Aaron, and Karen for staying on.
All right. Thank you for letting me speak. I appreciate it, Lindsay.
Of course, no problem. Have a great afternoon.
You too. Bye-bye.
Bye.